And in the interest of keeping things moving, we will go ahead to our last presentation here. Last, but certainly not least, we have our keynote presentation for you all today. I would like to welcome Dr. Barbara Jean Buckley and Danielle Wittal to speak on their research of building a model of community support for post-acute sequelae of COVID-19 patients with interior health, research evaluation, and care in a learning health system. So I will leave that on to you.
Great, thank you so much. Do I have the rights to share my screen?
Yes.
Yes, okay. There we go. This guy. Share and does that look good for everybody?
Yes.
Okay. Interesting that okay, let me slideshow maybe. There we go. Oh, perfect. Okay. So thanks so much. Our project is titled Building a Model of Community Support for Post-Acute Sequelae of COVID-19 Patients within Interior Health, Research, Evaluation, and Care in a Learning Health Systems. So my name is Danielle Wittal, or Danny Wittal, and I'm working with Dr. Barbara Buckley as well. So we're going to be sharing the presentation, so you'll hear both of our voices. So first, we'd like to do our land acknowledgement. We'd like to recognize and acknowledge that this research was conducted with participants living on the traditional, ancestral, and unceded territories across IH. And so from the north to the Daldane down to the Sequelae Nations, and Barbara and I are coming to you from the Sequelae territory today in Cameroons. Okay, so we're going to discuss a bit of background today. What is post-acute sequelae of COVID-19, or called PASCs. Also our post-COVID-19 interdisciplinary clinical care network, also known as the PCI-CCN. Learning health systems model, our research study and findings, and our phase 2 plans, and also we'll have time hopefully for some questions. And happy to take any questions at the end of the presentation. And you can also utilize the chat function if that works for you. Okay, so this project builds upon the post-COVID-19 interdisciplinary clinical care network in British Columbia, which their focus was on integrating research into clinical practice to inform quality improvement. So Interior Health has been an active member of the PCI-CCN since its inception, but lacked its own dedicated post-COVID-19 recovery clinic. And so with our region-specific challenges, a virtual model was developed to provide care closer to home, and with consideration for physician shortages and the need for equitable access for rural remote communities. So what is PASC, or post-acute sequelae of COVID-19? So that is defined as symptoms experienced following an infection with SARS-CoV-2 that is unexplained by an alternative diagnosis persisting beyond 12 weeks. It can be physical, cognitive, social, or emotional in nature, and can require psychological, social, and/or medical support and education as well. And so impacts from PASCs are significant because often symptoms are involving multiple body systems. And so about 10 to 30% of COVID-19 infected patients present with PASCs. And there's a growing concern that these patients could overwhelm the primary care system kind of immediately, but also long-term with complex care needs, essentially requiring future chronic disease management and rehabilitation. And so in our IH region, amidst the fourth wave of COVID-19, we experienced some pretty high daily counts of infections. Okay, so the PCI-CCN, so a bit of a mouthful, Post-COVID-19 Interdisciplinary Clinical Care Network. So this was developed in British Columbia to manage PASCs, and has been formalized, like the efforts to manage PASCs has been formalized through this network that has been developed. And so the PCI-CCN was developed as a care pathway to support patients and to deliver clinical care programs. And so there is a central intake in the Lower Mainland, which also with some access to our race line as well. It involved many collaborators, including clinical specialists, researchers, patients, and health administration to form a learning health systems. And so under the PCICCN, there were some PCRCs, which is post-COVID-19 recovery clinics. And so what essentially would happen is a patient would present with some random symptoms to their physician's office, the clinic, or the ER. And then after ruling out a variety of other illnesses and diseases, a referral form would be sent to the central triage at the PCICCN. And then if that patient met the criteria, they would be included in the network. And so within the PCICCN, their goal was to provide standard testing and education at regular intervals, kind of for a minimum of 12 months. And so as with most things, there's a lot of changes kind of occurred and shifts made to meet the demands of the population. But that's an example of kind of a learning health systems model, which we'll kind of discuss briefly next. And so the PCICCN started with one centralized clinic, and then they shifted to open a few more in the Lower Mainland and also one in the island as well to address the growing needs. Okay, so what is a learning health system? So this is a way to gather and apply evidence and kind of data in real time to generate knowledge and improve decision making. So with learning health systems approach, you can rapidly use the knowledge learned and translate that into action right away. So it allows for this continuous improvement, collaboration, and innovation within the healthcare system. And it can provide safe, high quality, more efficient care and healthcare delivery as well. So essentially, we're taking knowledge that we're learning and we're translating it to practice right away. And, again, it leads to health system productivity, improving patient outcomes and time and cost effectiveness. So it's this continuous cycle of learning, changing, and acting. So I will pass to Barb.
Thank you, Danny. So let's get to the study. So basically, we were tasked with developing a virtual community-based interdisciplinary team to help persons experiencing long COVID in the interior health region. And we set out to build this model not only to be able to help patients, but also to do some research around that and some evaluation. Next slide, Amy. Thanks. This sharing is interesting from different houses. Again, we're looking at developing a model, and this was unique. We'd never done this before, so we had to build it from the ground up. And using learning health systems. So what we were learning, we were changing as we were creating. Next slide, please. So we settled on a research question. We really were curious, would this interdisciplinary team, would this approach, this model actually support better or improve patient outcomes? Would we as healthcare providers like this new model? And if this was going to work, how was it going to work? And so that's what we were tasked with. And so that's what we're going to talk about today, is a study from model creation through patient care, providing patient care through the research, and coming back full circle. Next slide, please. So we had some lofty goals, of course, as with Sorry, muted myself again. So we wanted to bridge that gap. And those of you who are, doing a master's maybe or your PhD work, you've heard endlessly through the years around the gap between theory and practice and research. So we set out to try and to bridge some the gap there between that by creating this model. And along with that, creating some educational materials and resources for our patients in terms of patient education sessions and so on. And at the same time, as we were creating the model, we were evaluating it and doing some research on it, not just the patient's experience, but those of us on the team who were also providing care. Next slide. We had some objectives or some deliverables that were also in the back of our mind in keeping with our partnership with the PCICCN. We were having to maintain our patient records. Certainly that's part of what we do in healthcare. We were introducing standardized data collection tools. The PCICCN certainly had requirements over that. We had some requirements to evaluate our data and so on and so forth. So we had lots of objectives running behind what we were doing with this project. So mixed methods seemed to be the best approach to doing this study. And so we started off doing lots of exploration with different ways to go about creating a stand-up virtual clinic based here in Kamloops, but servicing the entire region. And that was a lot more complex than we thought it would be. So there was, Danielle will speak to that as we go on here. My part was to figure out how we were going to interview people and conduct focus groups, how we were going to put out surveys to both providers and patients, how we were going to look at the data collected through standardized questionnaires, a baseline when people came into the PCICCN, the provincial program, and then the follow-up surveys that happened when they were exiting the program. And with the qualitative data, how we were going to analyze those themes. So you're probably wondering, well, who is this team? How did you, who was on that besides Danny and myself? We had a couple of registered nurses that we pulled into the project. We hired a community-based physiotherapist and a social worker. We had a nutritionist, and we were fortunate to have a patient partner who was someone with long COVID. So this whole project started way back in August of 22 with this idea, and we worked towards creating the model, collaborating both within and outside of Interior Health with our different stakeholders, gathering resources, and by the start of this year, January of 2023, we were able to put boots on the ground and start bringing in our patients into the project. And so just a little blurry here on my side, just a quick snapshot of where our patients were located. So as you can maybe tell, the north there, north of Williams Lake, Lillooet, I believe was our furthest to the west. East out in Sparwood, got a little cut off there, and as far as south as the border in Grand Forks. These red dots indicate people that were actually involved in the clinic itself in Interior Health, but certainly there would be people suffering the effects of long COVID in many communities across the region that may not have been attached to our clinic.
Okay, so what did our program look like? So we had an RN visit accompanied with some group education sessions. So our physiotherapist provided the post-exertional malaise, known as PEM, the breathlessness and symptom titrated. So PEM essentially was just around understanding how energy is produced in the body and learning how to prevent some symptom flares and some practical kind of applications of just how to live and how to sort through having long COVID. And so this was 2-hour-long sessions. Breathlessness just offered an in-depth explanation of breathing and how it is affected by long COVID. And again, some exercises were given as well. These sessions were all very interactive. And that was 4 hours of a series of 4 hours. And then the symptom titrated was a gradual return to work that was safe for patients experiencing PEM or POTS, which is postural orthostatic tachycardia syndrome. And so all of these sessions that we had set up and created aligned with the PCICCN's classes, but were tailored to suit the needs of our patient population in IH. And so mental health, grief and loss, and long COVID and sleep were provided by our social worker. And so each of these were hour-long sessions. And again, just providing another option, tools and resources for people and some support for them. So the mental health session just talked about how COVID plays a role in our mental health and some coping mechanisms and resources and some just tips and tools and tricks to use. The grief and loss, it just defined what grief and loss is and explored some common symptoms of people that might be experiencing in relation to living with long COVID. And then the sleep, that was a big one for people. So people were exhausted, yet they had a lot of trouble sleeping. So this session discussed how COVID plays a role in changing of your sleep patterns and had some education and some tips around forming healthier sleep habits. And so this slide just shows some of the supportive care programs we offered. So nutrition, coffee club, meditation, and journal club. So the nutrition, I personally felt was something that was lacking from the program as it currently stood. So I felt that that was a really important aspect to just overall health in general. So we were able to find a nutritionist who's able to run a few sessions, and we offer that to the provincial programming as well. And so that was kind of consistent with some feedback that we were hearing from the provincial program, but also from our patients in IH, that they needed more information around that to just help their bodies heal, essentially. And so coffee club and meditation was also added, as well as journal club, kind of after we started going, after our one-to-one interviews, focus groups, survey feedback, and just general discussion. It was kind of realized that people are really wanting meditation. They're really wanting coffee club. We called it as a space to kind of connect. And just to form a real community, essentially. And so this is an example of that learning health systems model, where we're learning what patients' needs are, and we are changing, and we made that change immediately. And the journal club as well was a really neat one to add, and essentially that was from direct feedback from patients who were wanting to learn more about long COVID from a research perspective. And so they were craving more informed education around that long COVID. So we had set those up, and they were really well received, actually. And so throughout our programming, people had access to, as I said previously, RN visits, physiotherapy, social work, and also access to the PCICCN provincial specialists, and then the race line for GPs and NPs as well. So on top of providing the group sessions, we also offered one-to-one physiotherapy and social work to anybody who was interested.
Okay, so I'm just going to talk a little bit about the data that came out of the interviews, the focus groups, pre and post surveys, and talk a little bit about future research a bit. So Danny, next slide, please. Thank you. So those of you who love numbers like I do, so this was our life for 6 months. We rostered in 136 patients from the provincial group, PCICCN, back in January. A lot of them did complete visits with an RN. Some said they didn't need it. Some said they were fine. They didn't need to come to our educational programming. Some said, beautiful, love to come to programming. A lot of people were wanting to have one-on-ones with our physio and our social worker, and so those were offered. If you take a look at this rather huge bit of numbers here, I'll just draw your attention to the educational program hours. So we almost completed 180 hours of education for people that wanted to join over pretty much about 5.5 months time. For the research aspect of it, I had 24 individuals who wanted to conduct an interview with me around their experiences. And then we had an additional 24 people participate in 3 focus groups that we held. And from all this, there seemed to be a lot of interest and excitement with this population around research. And so before we wrapped up, we asked them, would you be willing to consent to be contacted in the future if there's possibility of research either with us, with Interior Health, or with PCICCN, and 63 of our participants put their hand up and said, absolutely, we would love to do that. So lots of activity happened in a very short period of time for these participants. Next slide.
Fine. Okay. So our IH program, it was really important for us to create a comprehensive supportive navigation model, which allowed for continuous improvement in innovation through this learning health system lens. And so I feel quite strongly that that's what we did. We were successful in that. So we developed, a program that was engaging and intimate and flexible. We centered the patient as a partner in their own care, and we provided a safe space for patients to connect, to receive care, to support and learn. And so after each class attended, we sent out surveys to just gather some feedback. And then we use that feedback to directly make those changes to benefit the patient and improve our programming. So as I had previously said, that was the coffee club, meditation, nutrition, and kind of journal. Journal club is some examples of this learning health systems model at work, and just how we also really help to kind of create and foster this community of support for patients. So this slide is, kind of basic, but it just shows you that, patients attended a range and a wide variety of our programming. And so the big takeaway from figure 2 there is that just most of the patients were happy with the care that they received. And so we just wanted to know if we were actually meeting their expectations, and so far so good. So the last question we always asked, is there something that you can tell us to better understand your experience or your needs or your journey? And so, most of the feedback was, they were feeling very informed. The programs are very inclusive. There was compassion, and there was really helpful. And then that feeling of connection and that not feeling alone. People expressed a lot of desire and a lot of kind of, I guess, joy, you could say, in knowing there's other people out there who feel the same way as them, because it was quite isolating for a lot of people. So this is just some results from our RN visits. And so again, our goal was to ensure that we were improving the patient experience, and then that people, were feeling that they were treating with respect and kindness, which is figure 1, which was, quite positive there, that they felt validated and heard in figure 2. And that they were feeling kind of supported, and that essentially that we cared about their goals and their recovery. And so again, most people strongly agreed, had a couple neither agree or disagree. Okay, so again, with the RN survey, just helping us to get a better understanding of where the patient's coming from. Kind of everything's kind of similar along the same lines, but they felt very informed, supported, understood, and grateful, validated, and listened to. A lot of people said it was great to know that they weren't actually crazy. And that essentially our program had been a lifeline for people. There was some feedback around that a couple people weren't happy that we didn't have a physician attached to our program, which is fair. But our program was kind of multidisciplinary led. So that's what we were trying to sort through. Okay. And so this quote sums up, I would say, the overall general feeling from people who attended our program, that I'm very grateful for the COVID team support with receiving information, participating in the programs, and knowing that there's ongoing research. I feel supported and informed. With these tools and knowledge, I feel I have hope of returning to my pre-COVID health and abilities.
So, as I said before, there was provincial level data that all patients going in their PCI-CCN had to come into the program completing a baseline survey, which was, I believe it was 8 pages long. It's quite detailed. And when they were exiting the program, a follow-up survey at same length was sent out to them. And then I have to give a big shout out to my colleague, Dr. Kathleen Scullion, for her work, helping me make some sense out of this provincial data. And so we're just going to go through a little bit of what it looked like for 58 of our patients in our program here at Interior Health that came into the program and filled out both the baseline survey and then also completed by doing the follow-up survey. So a little snapshot of those patients. So in the clinic that we had, the age range was between 20 and 79. And as you can kind of to the left-hand side, that bar graph there, the mean age would be 47.7 years for our particular patients. And that pretty much held across PCICN across the province, that the bulk of patients, maybe this will surprise you, sit between age 30 and 50. Not in the older adult group, which a lot of people think. It's mostly the young adults, 30 somethings, career type age people with young families, mostly impacted, particularly in our group that we had, looking at it from gender, those who self-identified as female, 60% of our group identified as female, with the remaining 40% being male. So interesting, of the 58 patients that we had, 67% of them participated in most of our education classes. So that was pretty good compared to the rates for the provincial program. Maybe it was, for a variety of different reasons. We did have smaller groups. Maybe it felt more intimate and connected for them, but we thought that was a pretty good rate of participation. Of the patients that we saw and that responded to the follow-up survey, we were able to ascertain that 40% of those said that they were better able, after going through the program, to perform usual activities. And what do we mean by usual activities? Well, that could be anything from work or studying if they were students. Maybe it was participating in care needs around the house. Maybe it was doing more family related or leisure activities, that they were better able to perform these. At least they claimed that in their follow-up survey. So what else did the comparison between the baseline and the follow-up tell us? Well, it showed us that almost 60% felt actually better at the end than they did at the beginning. And that gave us a great deal of hope that having a model like this might be something very useful. And the last little bit there that I want to bring your attention to is that 42% of these patients actually scored much lower on the feeling anxious, on edge, in their follow-up survey. And you're going, well, 42% lower. Well, what does that really mean? Well, it really means that it had an impact to improve their mental health and well-being. And that was quite exciting to see those statistics there. Next slide, Danny.
Mm-hmm.
Thank you. So apologies if you hear my dog. I think the mailman has a lot. So persistent symptoms. So people with long COVID have these symptoms that never seem to end. All of the people that I interviewed had what I call the long COVID trifecta. The three things that I saw in each one of them was what I call beyond brain fog. It wasn't just, oh my goodness, like I go into the pantry and I can't remember what I've gone in there for. No, their brain fog indicated a very concerning, very serious change to their executive functioning, their ability to process, and certainly had significant impacts to their memory, both their working memory, beyond going to the pantry to find something, but some experience changes to verbal memory as well. One of the questions that I would ask of my participants to kind of ascertain where they were at in terms of brain fog, some people said, oh, no, I'm fine. And I would say, so tell me, driving. If you've been driving recently, have you ever gotten lost driving? And their faces would change and they'd go, yeah, actually, yeah, I have. And then they would go on to reveal that they've actually stopped driving because of the seriousness of the changes with their brain fog. A lot of them were scared to drive. A lot of them didn't trust themselves to transport their children and so forth. All of them reported some kind of change to their psychomotor coordination, whether it was feeling more clumsy, stumbling, moving their body. They just felt that there was this significant change, this kind of weakness that had overcome them. And their fatigue was described as bone weary fatigue that not only impacted physical, but the mental, spiritual, physical parts of their personhood, and their energy levels could change and fluctuate, hourly, daily, weekly, such that they described rest would be work, even that it was draining to even be able to rest. So what else did our participants report in terms of long COVID symptoms? And these are quite common. We were just at a conference the other week in Montreal, and this isn't a complete list, but this is kind of the most obvious ones that people report. Certainly, it goes alphabetically. We don't maybe think of GI issues. Most people think of COVID as being an airway or a respiratory concern, but long COVID impacts all of our systems. The typical things: anxiety, airway, depression, insomnia, brain fog. Those things were quite pertinent and relevant. Lots of cardiac and blood pressure issues, and of course, certainly changes to the senses, taste, smell. One surprise was the change in vision and the tinnitus for people. And for our participants, a lot of them had what I noticed that they had anemia. So very interesting. Next slide, Annie. So in interviewing them and having them describe their life and what their life was like, they started to describe to me what their new normal was. That they really were not the same people that they were before. Most described their life as kind of the before and the after. They had a very hard time accepting this is their new normal. Most people didn't want to talk about it, didn't want to share with people. And as the quote here says, they didn't want to look at me like I was broken. Thank you. So I divided up the invisible struggle that people were experiencing in kind of the intrinsic and extrinsic factors. A lot experienced stigma. As you can imagine, losing your job meant a loss of social support. A lot experienced invalidation from other people. A lot felt or were called a hypochondriac, or told that, what's wrong with you? You look fine, that kind of thing, that toxic positivity. You walked to the mailbox yesterday, why can't you walk today? Many experienced and complained of medical and social gaslighting from people, from their physician or care providers. A lot, of course, had limited access to healthcare providers. And the problem with long COVID is that it is an invisible episodic disability that we don't recognize on many different levels, including, somebody's beating me in the mirror here. Including long-term disability and workman's compensation. So they experienced a shift in self, definitely had changes to activities of daily living. They had to learn to plan, to pace, and to rest. And for many of them at the top of their careers, the thought of resting, they couldn't even fathom how they could not go work and do the same things that they had done. They described their ability to ration their energy as something they had to learn to preserve themselves. If they started with a cup of energy during the day and it took half a cup of energy to have a shower, they might forego the shower that day. Next slide, in. So significant impacts to mental health, as you can imagine, are occurring for this population, suffering the stigma could be multi-layered and complex depending on your social situation. Certainly they suffer disadvantage and alienation on many different levels. Many lost employment, their careers, got sidetracked from school, said that their retirement plans were no longer possible. Social relationships were disrupted, families were broken up, and they were living with a great deal of uncertainty and still live with uncertainty. The financial stress broke a lot of people. Most felt abandoned, alone, lost. Everyone I interviewed, I asked them if they had at any point during their journey considered suicide, and all said that they had. And there were significant changes to mood talked about. Next slide, please. What did we learn? I learned that COVID has a very long tail. I think of COVID as kind of a dragon with a very long tail, disrupting the lives of the people it impacts. I learned that while COVID is episodic, it changes. It does not have a straight linear trajectory. It is up and down and all around, which actually made it very difficult for people to complete surveys. It was very difficult for them, not just the cognitive fatigue, but on some days they might feel well, but the next day, very terrible symptoms. So that was reflected in some of their ability to complete surveys. We learned that patient partners are absolute necessity. And we are very grateful for our patient partner. She certainly helped keep conversations going and informing us about what we were missing, where the gaps were. We were flexible. We learned to be more flexible. We learned that just because it's working for one individual may not mean that it's working for others. There is vast complexity in recovery, and that we need to be flexible to meet people where they're at on their journey. The consequences of long COVID are long lasting. The tail is very long, and it impacts all aspects. And we learned that we actually need to improve physician education. As somebody who does physician education, this was near and dear to me. So, Danny, next slide. Some outcomes. We met the outcomes. I'm just saying, somebody tell me I'm running out of time here. So the behind the scenes outcomes, yes, we created a virtual model. Yes, we believe we have improved patient outcomes. We actually had a really positive experience together as a team, creating the model and providing care. So the provider experience, we felt good about what we did. We've, of course, generated some knowledge and happy to share that. We believe the virtual model helped, particularly our patients with more in more rural and remote areas, be able to participate. And we think we've, increased access that way. And we believe this model is highly scalable and can be transferable to other aspects of the healthcare system. Next slide.
Mm-hmm.
Patients benefit. We think the public will benefit, especially looking long-term. Other diseases like COVID-19 will be emerging, and we will be more prepared to help deal with that. And we think this model actually, will be something that other healthcare networks could share with different chronic conditions. Next slide, Manny.
Okay. So as with most projects, we had some challenges and limitations as well. So time seemed to be the major limitation and challenge for everything. We didn't have a ton of time, but I think we did a pretty good job given the time that we had. Our model creation, we were creating a model under the PCI-CCN while tailoring it to our needs in IH. And so even it's very complex to develop a program, actually. So even the IT systems that need to be in place, all of that it was a lot, and it was really eye-opening into what actually goes into creating sustainable programs. We knew our program would not be physician-led. So that was like a gap for sure, but we knew that. But however, our inability to to find an occupational therapist was a surprise, and an obvious gap in our programming. A lot of our patients would have benefited from being able to connect with an occupational therapist. So yeah, that condensed time frame was an obvious challenge, and being able to connect virtually was really great in some aspects, but those patients who lived in rural and remote, we had some issues connecting with them. And so we adjusted and shifted, and we mailed patients information if they needed who didn't have access to internet as well. The patient cognitive fog was a big one, was very challenging. It was difficult for a lot of people to be on a screen for a long time, up to an hour. So even the thought of attending an online class was distressing for some. And so I think that made people not participate. We offered audio only options. Some took that up, some did not.
Hey, I know we're out of time. Kim, be gracious, give me 5 more minutes here, girl. So future research, just thinking, what did we learn? What can we apply this moving forward? Lots of opportunities, we think, for the researchers in the room here, looking at the broader social structures and economic impacts, certainly that are going to result from, increasing labor shortages, people with reinfections. We don't know what that's going to look like. Certainly, there are gaps in our understanding of the social impacts and unmet care needs. We do know that COVID has created an opportunity for other opportunistic infections to rise in everyone. So things like TB is on the rise, syphilis, all kinds of things. So there's lots of things, that long tail there of COVID that's going to impact future research. Definitely, there's opportunity to look at the episodic disability for this population and try and decrease that gaslighting. And we are going to directly address the gaps in education and supports by phase 2, which Danny, we're going to whip through here. Phase 2, we're going to look at what do physicians know, where's the gaps, how are we going to address that need, how are we going to implement those changes, how are we going to circle back to translate that knowledge, and how is that going to help support our long COVID patients in community. Next slide.
Okay, we'll quickly go over this progress chart. Basically, we are now in just July to December of 2022. We're working on phase 2. So hopefully we started back in September of 2022. So hopefully we are planning and enacting phase 2, and hopefully to complete by summer of 2024. So stay tuned, and hopefully we'll be able to bring you the results of phase 2 next year. Special thank you, right? It wouldn't have been possible if we didn't have the support of the patients, families, our incredible patient partner, a steering committee who started this, the past, the present members, our colleagues at the PCICCN, the PHSA, and our own research team in IH here.
So I just wanted to end with this one key takeaway message that I share with you. The burden of self-advocacy and care seeking for this population is far too heavy for long COVID patients to carry alone. I think it's up to us to help them carry it. And I give the last word to my friend, Nikita Valero, who is a PhD student at the University of Alberta, and she lost her father to COVID. And I think her words speak to everything that we've learned about this COVID project. Shouting self-care at people who actually need community care is how we fail people. And Danny and I are determined not to fail our long COVID patients and the patients that are attached to this clinic, and as we move forward with our research in the future. Thank you so much. Let's turn it back over to Kim and Amanda.
Thank you so much, Barbara and Danny. This is such meaningful research that affects so many people, not only here in Interior Health, but globally as well. And thank you so much for sharing today. We've had some great questions come in through the chat, and we will make sure that we send those over to you, and we will respond later on to everybody who has participated in Interior Health Research Week. However, I would like to finish off with just one question here that's come in through the chat. This one is done by Callie. And Callie is wondering if you separate patients who have long COVID, but also have other medical comorbidities from patients who just have long COVID.
Not in terms of participating in the research. Of course, many people that had long COVID have some comorbidities attached to them. And as they entered the PCI-CCN clinic provincially, I mean, those would have been identified, certainly. Did they add additional complexity? Yes. You know, more so than normal. No, I think that the burden of long COVID for most of these individuals actually overlaid their other chronic diseases, that it became so overwhelming to them, you know, that became their priority, not their, you know, their diabetes, not some other things.
Of course. Thank you, Barbara, for that answer. And as Kim has said in the chat, there's a great call for community connection, and this study is bringing this. So thank you again for presenting today. And thank you everybody who has attended and who bared with us through our technical difficulties at the beginning of this session. If you are still here in the room, please make sure that you help yourself to snacks and drinks before you leave. And once again, a special thank you to all of our presenters today. So both the clinical research department throughout Interior Health, both the research coordinators that contributed to that video that will be sent out again later on. A special thank you to our UBCO students, Madison and Lindsay, and then of course to yourselves, Barbara and Danielle, and then all of our tech support here as well today, and Kim and Tess who are in the room and supporting me so I didn't have a meltdown during those technical difficulties that occurred. And once again, just a special reminder, please do join us for the last day of Interior Health Research Week 2023. It's going to be on October 18th, and we can't wait to see you all there. Thank you for staying with us today, and I'll let you all get back to your very busy days.